All right, I think we're gonna go ahead and get started. And I am always fashionably late, so we will respect whoever shows up in a few minutes. My name is Melanie Parker. I'm a physical therapist, ATP, SMS. I'm a seating person. That's what I do all day. So just gonna share with you some of my mistakes over the years and hope that you learn a little bit from it. So I've been practicing for 21 years, and so my practice can drink now, and sometimes it wants to. So I'm hopeful that you can glean from some of my experience. I do not have any disclosures other than my opinions, which are free with the price of admission. You can take any of them with you when you leave. We're gonna get started. I kind of just want to know who is here. So like, raise your hand if you are a therapist. Keep your hand up if you do seating as the majority of what you do in a day. Okay. All right. Hands down at suppliers. Okay. Anybody else just here for fun? Okay. Good job. You guys in the back. That's awesome. Well, thank you for being here. And I just want to stop and not to be too sappy, but just thank you for what you guys do in a day. I know it's hard. I know it's frustrating. I know we all want the best for our patients, or I prefer to call them clients. And you'll hear me reference them as clients throughout the presentation. That is because I very strongly believe in a client-centered model. I'm there for them. It's not about me and my credentials. It's about them at the end of the day and them having a successful outcome. So you'll hear me refer to them as clients, not patients. So yeah, so we're going to just jump right in. Give me 1 second. Okay. And the little clicker thingy is not working. Oh, we have this. No, we don't have that. Sure. Oh, look at that. All right. Those are fun objectives that you can read for yourself. So we're just going to talk about a lot of different things to consider. So some of the things that we're going to talk about measuring, some of them will have actual numbers attached to them, and some of them will not. So, but they are things that you should measure in your, as far as consideration of their importance and how it relates back to what the end product recommendation is for your client. All right, this is my theory. Again, my opinion is free of charge. So my theory is, if you're doing the same products over and over and over, you're not likely you're likely not measuring something. If you tend to, like, this is your go-to, and 80% of your clients end up with the same configuration, I would challenge you that you're probably not measuring something. So hopefully the things we talk about today will kind of spur some thought, like, oh, maybe I haven't considered that. So that's my challenge to you, is to think about those things. So with all the pens that you've acquired from downstairs or on your phone or any other device, I would like you to actually do this, to write down either on your phone, a piece of paper, wherever. We're going to take 60 seconds. I will have a timer going. I want you to write down everything that you try to measure and assess when evaluating for a client for new chair, whether that, again, is something that results in an actual numerical measurement, or if it's just a consideration, something that you weigh heavily when you make your decision. So everybody got something to write, because there's going to be a game actually attached to it. So if you don't do it, you can't win. All right, are we ready? 60 seconds, go. Thirty seconds left. Ten seconds, right faster. And time. Okay, we'll come back to that. So look at your list. or think about it for those who didn't write it actually down. What is the most important thing to measure? Just kind of along those lines of like you're going to be stranded on an island, you got to take only 2 of these things with you. All right, which of these things do you think is the most important thing? Say again. How long they're going to be in it, seat width, seat depth, purpose of the chair, how they're going to move around in it, seat to floor. All these are great answers. Okay. Like I said, my opinions are free. With the price of admission, my answer is what's the client's goal? What do they want to do? Okay, because everything kind of hinges on that. All those things you said, absolutely. That's my answer. It doesn't have to be your answer, but that's my answer. So, and the research shows what we already know. So when people are given an individually configured wheelchair, that they have safer and more effective use of their chair than people, and this was a study for people in the facility, the residents that were provided with a facility provided chair. This is not shocking evidence to anyone. So the first thing that we're going to talk about is those anthropometric measurements. We have to do this, so because you're not really you better be doing this or we have a real problem. So you probably already doing this, but we're just going to kind of roll through these quickly just to kind of as a refresh, just to bring them back to the forefront. So this is our little peoples and all the things that we tend to measure. Thank you, Permabill, for the cute picture. So let's go with them. These are all the things that you measure, right? Main ones, there are more, but these are the main ones. So why do they matter? So this is the column of why they matter isn't obviously not an exhaustive list, but it's kind of the crux of it, right? Seat to top of head, the wheelchair doesn't need to be taller than that, right? The seat to top of shoulder, the back usually doesn't need to be taller than that. The seat to axilla, that for an active user, that's usually the top of the height you would want to go to not block their scapula. If movement with self-propulsion, or that's where you probably want that lateral height to really get them stable and midline. The seat to elbow, the armrest height, the upper leg length, that seat depth, plus or minus a bunch of other factors that we'll talk about. Lower leg length, seat to floor height, plus or minus a bunch of other factors. Seat to footrest length, plus or minus some things. The shoulder width, you don't need the back to be wider than that. The chest width is, again, that lateral trunk width. That's that inner width you need to think about when you're doing a deep contour back. The hip width, that's the seat width, plus or minus some things that we'll get into. And then that foot width and length is that foot support size. So this is just hitting the basics. Okay, so here's some other body measurements that you're likely taking. So height and weight, obviously by regulation, should be documenting that. But obviously, you also need to know that versus the intended weight capacity of the device you're looking at. That might help narrow that decision tree down. The gluteal shelf, we are not getting smaller. So that gluteal shelf is, so let me use that little handy dandy. Where's the little thing? Right there. So like that D measurement almost. We need to consider the height of that as well as the depth of that. So when you're looking at your back, what back you're going to use, otherwise their butt is going to touch the back, but the rest of their back will not if you're considering that. So that gluteal shelf minus the seat to top of shoulder gives you kind of that back height that you're looking for, but as well as the depth of that gluteal shelf. You need to know what your hardware adjustment is to get that backrest actually to them and how you're going to work that out. The widest part of them may not be their hips. So looking at what is the widest part when they sit down in the chair, is it their thighs? Is it their knees? Is it based on edema? Is it flexible? All of those things you really need to look at. What is their widest part? Edema, we think of edema a lot for the lower extremities and how that's going to affect positioning and how you're going to manage that. But also, if you're looking at cushions, scrotal edema, it's not, can be an awkward conversation, but you want to manage that well, especially, in their seating so that you're helping with that. You're accommodating that so that they can be comfortable, especially in custom seating, that you can really customize that that well, or as Ride Designs says, the GBR or the Grand Ballroom, to give that space so that you're giving them proper support that they can sit. So those are some things you might want to think about. All right, so scoliosis, is it progressive? Is it stable? Can you reduce it? How are you going to reduce it? Is the way that you would maybe think to reduce it, how is that going to impact their function? Is it going to restrict them too much? As well as if you're trying to position them, do they have rods? Like, are you pushing against a barrier you shouldn't be pushing against? Is that going to cause them pain? So sometimes if I'm questionable, then I may try to reduce it and then leave them in that position for whatever period of time that I can while I'm asking other questions, so that I can see, is it starting to get uncomfortable? Pelvic asymmetries goes right with the scoliosis. Fixed or flexible, what's going on? Can you accommodate it? Can you correct it? And then what does that do to the rest of the body? Kind of the basic premises of seating. We start with the pelvis and we try to work your way out, because that is their base of support. And if that's crooked, they're crooked, and it's not going to work out. And then also their pelvic asymmetry. How is that contributing to their skin health, right? Fluid versus foam. I don't know about you guys, but in the area of where I live in Virginia, I feel like every wound doctor only knows about RoHo, and that's all they think is out there. If you have a wound, is RoHo, and they don't consider what are you doing long-term to this person's posture and function. And then too, if you have somebody with, that pelvic asymmetry over time, you can pressure map them and it's still going to look terrible, because there's no way to even it out. So you kind of have to configure the chair around those things and consider that, so you're not setting them up for other issues. But we want our client to be comfortable. We want them to be stable. We want them to have that function, but also consider what's going to happen long term. If you leave them in the way that you're configuring it, you need to think down the road. What are the consequences of what I'm doing? And then two, your documentation and your consideration of that scoliosis and pelvic asymmetry, is that going to be reasonable to achieve your goal and their goal with off the shelf, or do you really need to move into custom? Because that's your criteria for coverage, right? You can't fix it with what's out there off the shelf. Then that's your justification right there for custom. Contractures on the legs, that changes that effective seat depth. If you can't get my leg to a 90-degree knee angle, then that reduces my effective seat depth, right? So I may be 18 in the femur, but if I'm back and from my butt to the back of my calf is 15 inches and you put me in an 18-inch seat depth, we're going to have a big problem. Does that make sense? Nod. It's after lunch. We're struggling. It's Friday. Okay. All right. Upper body contractures, and how does that affect postural control and functional reach as far as their shoulders and elbows? And then in their head, their ability to see their environment. So even like this guy here, looking down at the floor, how can you manage that in a way that's not painful, that's promoting good upright posture, but not, again, you want to create a system that they're, at the end of the day, they still like you, right? Okay. So can the seating system adapt to change? There's a lot of great options, but if there's somebody who's still growing, or they are in a disease process where there's going to be a lot of fluctuation, then that needs to be considered. So if it's a younger person and they're going to grow, I don't know why, and I don't know if anybody else has seen this. I feel like particularly males with disabilities, like developmental disabilities, have this growth spurt in their 20s, and it's like everybody's like, what happened? I thought we were past this. So considering all of those height, length, growth things, what's going on, weight fluctuation, whether it's because of their disease process, because they're less mobile and they're putting on weight, is it because of the medication that they need to take, the steroids or whatever? Is it part of their disease process, like a congestive heart failure or some other thing that's causing them to hold a lot of fluid, and so they're there's a lot of fluctuation or trending upward in their weight. Coats, love this. My back looks great, but how am I going to get a coat on her? So what do you guys say when they say that? Just out of curiosity. A down coat that can be squished. What else? Please don't. Yeah, please don't wear your coat all day. I also say, hopefully they're not in their coat while they're inside. So can you put the coat on backwards and take it off when they get there? Or can you, or talk about poncho style coats that would go over them and over the chair as well. It's a lot easier to get on and off. But you can, for people who really have that desire, their clothing is bulkier in the winter, they dress in layers or whatever, that like summer, winter hardware, other hardware that will allow maybe a little width in that lateral support adjustment over time, that they can do that for the fluctuations. So changes in tone. I see a lot of people as they get older with cerebral palsy or whatnot, and they're really fighting that tone more and more as they get older. And so looking at the changes in tone over time, if they are going to have a surgery, did have a surgery, the baclofen pump didn't work, they're not a candidate, all those things, what's happening as far as their age, their disease progression, particularly those with seizure disorders. Find that sometimes that's a little harder to, depending on the disorder, harder to chase down over time, and that how that affects their tone and their positioning ability over time. Other people see, yeah, we're struggling. So you guys nod at me. This is helpful. Okay, good. All right. So the good old manual muscle test, and this typically falls obviously more to the therapist, but in this lovely age of telehealth, where the therapist is not there and the supplier is there, the supplier is our hands. And so it's important that you understand what we are looking for and what this means and why we're documenting it and why it's important. That being said, I don't think it is a supplier's job to tell me correctly that this patient is a 4 out of 5. I think that's for me to interpret, but that subjective data is really important. But I have had suppliers say that they're a 3. And it's like, I just saw them lift all the way against gravity. I could tell they resisted you a little bit. They're not a 3. So this is, if you're not familiar, this is the actual manual muscle testing grades and what that is. So a 0 is no visible contraction at all. They're totally flaccid. 1 is a visible contraction. You can see the muscle jump, but it's not producing any effective movement. 2 is full range of motion, gravity eliminated. 3 is that full range of motion against gravity. And then 4 and 5, you're getting into the level of resistance. And there are like pluses and minuses, but that's beyond what we're talking about today. So that's just a refresh for those who aren't as familiar. So why is that important? Well, hopefully the doctor is looking in that, and seeing that, but it's also for us to interpret what's going on. And maybe they seem more functional than they actually are when you do those isolated movements. So you're going to capture a whole lot more when you actually do this manual muscle test than to see what their real deficits are, and capture more than if you are just observing them. So as well as capturing pain and joint things. So you go to resist that shoulder flexion and like you see them wince or jump or they cuss or something to tell you that it hurt. So that gives you a lot of good information for your justification, right? So that shoulder flexion, that's the most force producing for manual wheelchair propulsion. So if I can't even do it full range against gravity, then my chances of being like a really great community propeller without causing damage to my shoulder is not very good, right? So just being able to take those manual muscle tests, but not just documenting, but incorporate them, and therefore this means blah, 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 blah. So that range of motion, that elbow flexion, if they're contracted, they can't even get back up to the starting position to push the manual wheelchair. So if I can document these things, I'm already ruling out manual chair, right? If that's the direction they want to go. Elbow extension, again, that push stroke, the functional reach, the grip, the wrist extension and flexion in the grip. Now we're looking at, can they control the wheel or can they control the joystick and where does it need to go? What does this look like? There was an article, Gagnon, in 2016 that said that grip was the greatest predictor of manual wheelchair efficiency, which I thought was interesting. So then we're looking at power or some other alternative. So the hip flexion range of motion is a big one that I think people miss, that this person's sliding out of the chair all the time and they just want you to put 14 more straps on there and we'll all be okay. Well, how about we look and see that they don't actually have the hip flexion to sit at the angle that you're asking them to. You know, it's like, and then everybody's like amazed that they're sitting up straight because you added a little recline. So that hip flexion is a huge win for documenting the need for recline. Knee flexion extension, obviously the positioning angle that they can tolerate, as well as do they have enough range to even foot propel. So all these things, as you can see, lead into your justification, your decision tree of what you're thinking is going to be functional. And then the foot, that angle adjustable foot plate, is that necessary to give them stability on the foot plate? Okay, so you've taken that measure, that's great. You captured 30 seconds in their day of what their strength looks like. So then ask them, if I did this later on today, if I came back to your house at 9 o'clock at night, would it still look like this, you think? What would be different? What's difficult for you when you first get up? How's that different than the end of the day versus the middle of the day? Especially these neuromuscular conditions, you really have to dig into some of that. Sometimes people don't want to tell you. Like this is already a vulnerable enough experience. Some things you just really got to draw out. And then they can have great strength and terrible motor control. So it's also making that very clear to the reviewer, like that you're ethically documenting that they had 4 out of 5 strength, but then you have to say, but they couldn't do a finger to nose test. They can't bring a cup to their mouth. They can't, their coordination is something we need to look at. Their deficit isn't necessarily strength, but it's coordination. Or even like in your more cardiac patients, that they could do the muscle test, but did you check their oxygen sats after? How long did it take them before they could do something else? Like they might have a good initial strength, but can they do it repeated over time? Does that make sense? Nod. Thank you for the nodders. Okay. Not these nodders, but the nodders. What about in their day, in the medication, back to like your Parkinson's patient, like that's great. Maybe you saw them when they took their meds, but then I asked the question, what does it look like? What does your mobility and function look like right before you take that next dose of medication? Or how do you know it's time to take it? Like what's going on? What does that look like? And if they won't tell you, the people they live with will. So be sure to document that and consider how their functional mobility changes as the day progresses and their medication wears off. So, but not only what does it look like, but then start thinking, what could it look like? What wouldn't be necessary for them to be like, yeah, I can function all day long? What does that look like? Some things we can fix with the chair, some things we can't. All right, vision. So we've got acuity and we've got field cuts. So acuity, how well can they see? How clear can they see? Field cuts, what can they actually see? And what can they do to accommodate for that, right? And how does that affect their function? An example I like to give is I did a custom mold for a client, but I molded him this way, not this way, because we realized the only accurate vision he had was the lateral half of his right eye. So if I set him nice and pretty in his chair, he couldn't drive. But if we angled it just slightly and let him be windswept, he could drive. So you have to sometimes think out of the box and what's going on, how does it inhibit, how can we work around it? So make sure you're testing their vision, not just asking, can you see okay? Yeah, I can see great. Okay. And then it's like they're running into the walls. So mental capacity to learn determines the complexity of the system. I have used this a lot with people who have some intellectual disability that may require a simpler system as a justification of why I need the electronics to go through the joystick and why 1,400 switches and buttons is not going to work. But they can understand this one thing, or however you need to make the system simple so they can understand. I love this article that children as young as 14 months old can learn some degree of powered wheelchair driving competence. That's huge. It was such a great thing. I mean, and not just, when we consider our client population that's developmentally delayed and where they may be intellectually, it still fits that mobility leads to learning, leads to intellect. If you can't explore your environment, you don't learn cause and effect. You can't interact with your environment. You can't really socialize. You're really limited in what you can do. So giving them that independent mobility is huge. I really, sidebar, but I particularly love messing with group homes who bring people to me and they're in a manual tilt and space chair. And I'm getting ahead of myself because we're going to talk about ADLs in a second. And I say, can they feed themselves? And they're like, oh, yeah, they can feed themselves, set up. They do a great job. Then why aren't they in a power chair? What you just told me is they understand how to operate a system, and I have the hand-eye coordination to feed myself. Why can't they drive? Well, we don't. Nobody's ever. Let's talk. So that's been a lot of fun. So tone, force, and frequency of movements. Do they have strong repetitive movements? Do they have strong extension patterns that you need to think about? How do they stay in the chair? Are they somebody who just breaks everything? Like they just hulk through everything. And their caregivers and their supplier will tell you they break everything. So trying to figure out like what you're thinking about and how durable is that system. Oh yeah, no, it's a future article. It hasn't come out yet. No, it's 2014. Yeah, no, I did it for you. So you could, when you switched it, it was right. I think that's amazing. You know what? No matter how many times you go through these articles, you always find stuff, but I'm the person who does that. So I respect you. Um, okay. So pain. So obviously we're looking at their pain. When do they have pain? Where do they have pain? All the pain scales, that we tend to look at. I like to ask if they have pain in sitting, where is it specifically? And that helps me figure out what cushion I'm going to go for. Like if they have more coccyx pain versus IT pain, I think some cushions do better at alleviating one versus the other, all that kind of stuff. Pressure mapping, which I know is not something that we can all do, and there's limited things right now on the market for doing that, but it does offer a great snapshot in time. It's not something that I live and breathe by, but I think it does provide good information. But again, it's typically a snapshot in time to identify where and how are they loading, and potential causes of discomfort. But I do like this article from 2000. I did get the date right on that one. That was easy. That showed that they using a minimum sampling time of 5 minutes and then averaging those 5-minute samples over dynamic movement is what was more reliable than a single discrete sample. So you're getting a better snapshot into their life. And I love these research articles and I hate them because I think nobody has time for that in their clinic. This is not real life. But I think it's important to take away from that, not so you can feel like you're a horrible clinician that doesn't sit there with them for 20 minutes pressure mapping, but because to realize this is a snapshot in time, right? It is important information, but if you can't leave them on there and do all of that, it's a snapshot in time. So guard that when you make your decisions, right? It's also pressure mapping. If you're not using it for biofeedback to educate on pressure reliefs, I think that is probably the biggest win for me is they actually see, this is why I need you to tilt and recline. You see how it all just went away all of a sudden magically? Look at that. Let's recline. So that's huge. Okay, so ADLs, fun stuff. So asking not only how much help do you need, but how do you do it? So, and that will give you a lot of information. So how do you get dressed? And maybe that affects the lateral depth that you have. Maybe you choose to do swing away laterals instead of a deep contour, right? Do they need to recline? How do they do that? Are they doing it by themselves? What is the caregiver preference of how that happens if they have a caregiver? Are they needing to catheterize in the chair? Are they using a urinal? Do they need access to somewhere to put the urinal, right? So if you're doing this big wedge cushion and they need to use the urinal, we got a problem, right? By the way, most of these things are in here because I made these mistakes or saw somebody else make them. So this is my list for a reason. Oh, I forgot to say this. I apologize. So you can go back through. As I say these things, if they're things that you wrote down on your 60-second list, cross them off. So you can go back and do that. It's kind of like bingo. So yeah, meal preparation. What seat height do they need to do that? Are they cooking? Do they want to cook? Are they able to cook? What would they need from the chair to be able to do that? And how can you include that? How can you incorporate that? Do they need and want to do laundry? And how does that look? Is it that stackable laundry or is it a front loader or how does that need to happen? Okay. Functional measures, how are they going to self-propel? So we'll go with manual wheelchair mobility here. Seat to floor height, I heard, so kudos to you guys. You can cross that off your list. So this was an article that said that lowering the seat height by 5.08 centimeters, 2 inches for us in America, that corresponded to a pretty significant difference in their efficiency. So really looking at that seat to floor height, so 2 inches below the lower leg length, sorry, that corresponded to significant improvement in their push on smooth surfaces and their perceived difficulty as well. Go ahead. It's up to you. And I 100% agree, and I say this to my clients all the time. Everything about this world is compromise. Everything. Like, there's rarely this unicorn chair that I can give you that will check off everything that you want it to do, right? You want it to be able to go 40 miles an hour and break down into 1-pound parts and right, like, it's not gonna happen. We gotta figure out which is why my number one is what is your goal? Because then I can that helps me figure out where our compromise is gonna be, right? Like your group 2 clients, it's like, "Look, I can give you portable or I can give you comfort, but I can't give you both." Right? So, but I put the ball back in their court, so I'm not the bad guy. So functional, but great point. Functional measures, how do they transfer? How much help do they need to transfer? Is that consistent? Is it improving? Are they getting better for whatever reason? Or is it declining? Could it be better if their chair system was better configured for them? But what would that need to look like? And then the technique that they use helps me determine the contour of the back. Again, we're back to that deep contour back, and I want to do a lateral slide over, and I'm really okay hitting my butt across the wheels as I go. That's how I do it. Or I, do the tuck and roll into bed myself or whatever, and all these barriers of your awesome seating system to sit them up so pretty, and now they can't get out of their chair. So this is where our compromises need to come in. And good old Musa back there, seat to floor height for level transfers versus elevated for caregiver transfers. Transfers are so super important as far as that height. Do they need to reach the floor? That people, again, you sit them up really nice and pretty and they feel comfortable and they like it. They're like, but I can't pick up anything off the floor. So without scooting to the edge of my seat, holding on for dear life, leaning over and hoping the whole thing doesn't flip. So we have to figure out all that. So I would say encourage more movement if possible as it relates to their function. This article from 2016 said that concluded that seating evaluations should emphasize positioning individuals in a way that facilitates reaching, leaning, and transferring in a safe manner, not only to improve function, but also to affect buttocks loading. So what is the goal for the seating system? Is it status quo, or is it we're going to improve, or we're combating decline? Like, what are we doing here? Like, we want them to functionally reach. We want them to do all the things, right? So what's the goal? And back to my group home client, what's the goal? Is the goal for more independence? Is everybody happy with him in a tilt and space chair and feeding himself? I can't be the only one on the battle line fighting for independence. Like, you can see it. You can see that there's potential for more. But if we did this, then you could do the laundry and cook. And they're like, I don't want to do the laundry and cook. Or maybe their caregiver doesn't want them to cook. Like, those things, like you have to figure out that's why it's their goals, not my goals. I can write goals all day. We're trained to do it, right? But if you're the only one on the battle line of independence, it's a losing fight. You've got better fights to fight. Okay, risk of skin breakdown. Yay. So this is the Braden scale. Hopefully it's kind of a lot, but you're familiar with the Braden scale, usually that you're documenting sensory perception, moisture exposure, how active are they, all of that, their nutrition, friction and shear, all of that to give you a number if they're at risk, right? And insurance loves for you to have that information there. So some considerations regarding skin breakdown. I'm just gonna do that. Skin health versus their ability to pressure relieve versus the ability of the cushion or tilt, something like that. Incontinence and how often are they changed? How is it managed, right? So that wipeable cover, that non-absorbent thing that when they're cushioned, and the presence of or the history of wounds, because we know though that area may have healed, it's always going to be at risk to reopen, right? So what does that look like and how does that affect your cushion selection? And if it's non-healing, why is it non-healing? Is it because they're non-compliant? Is it because they're a smoker, they're diabetic, they're, who knows? Like what, you need to dig into all that stuff. Just for your after lunch pleasure, there's pictures of stage 1 through 4, just so you can remember, stage 1 is just that deep tissue redness. 2, the first layer is broken. 3, we're down a couple layers. 4, we're all the way down to the bone. Random, but learn my lesson. If they're a smoker, whether it's cigarettes or pot, whatever, please avoid the air cushions if possible because they pop a hole. Say again? Or needles. Yes. Yeah, cats. Like scratch. Anyway, those are the things. Yeah, that too. So document the Braden score, but also document other risk factors because I see a lot of people who maybe they don't score at risk on the Braden, but they are absolutely at risk. So there are a lot of great cushions, but there's not one cushion that's perfect for everyone. So I'm going to go back to my soapbox of if you're doing the same cushion over and over for everybody, maybe you're probably not considering anything because there's not the one amazing cushion. This article in 2024 said it's clear that not one cushion is ideal in managing all aspects of microclimate, as foam gel cushions were the superior cushion to manage temperature, which I thought was interesting, and foam cushions were the superior cushion to manage moisture. I'm not really sure how they got that, but I thought it was interesting. So, there's your kitty cat. So now we're going to talk about the house. So home measurements that you need to look at. You got to take these. You should be taking these. The door widths, the turning radiuses, steep ramp inclines. So what sometimes I ask is like, all right, take me through, you're getting out of the vehicle that you got home in, whatever that looks like. How do you get to your bedroom? What do you have to do? You have to go to the back of the house and then you got to go up this ramp and then you come in the door and then what are you looking at? Okay, so if it's not telehealth where I can see it myself or they don't have pictures, have them kind of literally walk you through it so that you can kind of capture where are those difficult places. If they're already a wheelchair user saying, can you get everywhere in your current chair? Where is it difficult? Where do you not go that you would like to go? So just considering that as far as like those tight right turns, if you're looking at power mobility, maybe a front wheel drive would be better, those kinds of things. How are they going to access the stove, the laundry, the sink, or will they? Is that not an issue? Who cares? You can't make it to the kitchen because you love that your mom cooks for you and you don't want to get in there anyway. So those are the things that we need to be asking. Pets and durability of equipment. We talked about cats and air cushions. I threw the goats in here. For those who live in rural areas, I've had people in power chairs, the goats ate the wires on their chair. So just educating them that the chair should probably stay inside. Because if they say, I don't really need the chair inside, I'm going to leave it outside for the most part. All right, but do you have any goats? How many have asked that question in the vow? Nobody? Okay. All right. Outside the home, this is my big one. Where do they want to go and what would they do when they get there? Where do you want to go? Like, what are your goals? Yes, funding, yes, in the home, yes, blah, blah, blah. We know all that. But these are whole people with a whole life. Where do they want to go? let me think about that, right? Let me try to create as close to that unicorn chair as I can, right? So where do they want to go? What's that terrain look like? What's the seat to floor height for what they want to do? We're back to the goat people who want to, live on a farm. They need to go feed the animals. They need to milk the cow. They need to get their chicken eggs, whatever. Yeah, I had a guy who had a bunch of dogs and he needed to go take care of his dogs. And so he needed the chair to be able to get up his gravel driveway, and he needed to be able to bend down and undo the gates and feed the dogs. That was super important to him. So looking at all that, and as well as the durability of the product that you're recommending, is it going to be durable to what they want to do? Because guess what? They're going to go anyway, right? They're going to try it, and then they're going to be like, so my chair. So let's think about it on the front end. Do they have steps? What's the plan for that? And what's the pathway we talked about from the vehicle to inside? Just walking through, literally walk through their whole life, their whole day, and think about this. And I know it sounds like a lot, but if you get in the habit of integrating some of these thoughts into the way you ask your questions, and you're already storing this information. So you're not like, oh my God, I don't have 3 hours to do an eval. I know you don't, but it doesn't, you can get this information. It's not as much as you think. Okay, everybody doing good? Marking off their stuff? All right. So caregiver, this is super important. How much support do they have? How many hours do they get? When are they there? What parts of their day? If they have a caregiver at all. And then what is their function during that time? Is a caregiver there during their best part of the day, or not? Sometimes they're not. What do they do differently when nobody is there? Might not be an answer you want to know, but we should ask it. And then what about your caregiver? How much can your caregiver lift, right? Like they love that. I want a scooter. Well, I want this chair that breaks down. Okay, where are you going to go with it? Well, I'd like to go to doctor's appointments and to the grocery store and to the mall. Okay, who's taking you? My grandmother. How much can your grandmother lift? 5 pounds. Okay, let's talk about this. So, that is super important so that you're encompassing their whole life. How invested is the caregiver in this process? Huge, because they can have all the goals they want to, but if mom makes all the decisions and they live with mom and mom's going to veto, then again, we're at a place where we can encourage them to advocate for themselves, but you got to know who's on the battle line with you, right? As well as how complicated can the chair be and the caregivers not feel overwhelmed by it or intimidated by it? How many different caregivers are there? How many people work with group homes or facilities, multi-caregiver environments? Right. So you know that there's going to be an educational hole, a black hole of education, a desert, where if you have a lot of different caregivers, a lot of different turnover, then the system needs to be very self-explanatory or easy, or things are going to get broken because people are just going to push buttons and pull on stuff, not knowing what they're doing. So consider that when you're doing that. So a lot of times for me, if I'm on the fence of custom seating and it's a group home situation, depending on the group home and my experience with them, I may or may not do custom. Or maybe if I'm doing a ride, it's an AccuSoft, not a custom too, because I need to work in that variability of caregiver error, right? You just got to bank that nobody's going to do it the same. If you've got 10 people doing it, very unlikely everybody's going to do it the way that you would want it done. So that's the unfortunate reality. And then historically, how well do they take care of equipment? So again, avoiding things that are high maintenance if possible. We don't want the client to lose, but if you're giving them the system that's super complex and caregivers are breaking it out every other week, then they're not going to have access to their chair anyway. Okay. Social, emotional, and cultural. Raise your hand if you had that on your list. Okay. This is something that I keep coming across. So I was really intent to include this. So what is the perception of comfort and good sitting posture, and the perception of how often they should be out of bed, tilted, repositioned, all those things? Has anybody done like custom seating, especially if you've done a more firmer material like Matrix or Ride, and they sit beautifully and they're offloaded, their skin is safe, and the caregiver's like, they're just uncomfortable. I know they're uncomfortable because this is so hard. Has anybody heard those? Yeah. Thank you for waving. Appreciate that. So you have to think about, really educate them on the front end. This is what it's going to look like. but this is the science behind it. This is what we're doing. Time to acceptance. How acute is their disability? You might be thinking like, look, you really just need a power chair. And they're like, no, I still think I'm going to walk. I just want a manual chair. All right. Like you have to do that dance with them, and their acceptance of decline. Most of the time, I'm the first one to say this in an appointment where it's the scooter all day and they really need something more and they just don't want it. They want a manual chair. They want something that you know is so inappropriate. And they're giving all these honestly kind of semi BS reasons about why. And so I just say, look, if it's because you feel like people will see you as more disabled than you think you are if you go with this chair, or you feel like this chair is giving up, it's okay to say that. We can be honest with each other. And then sometimes they just start crying. And we deal with it because they need to talk about it. Like their emotions are not outside of this process. What if this was you? Your whole life has changed and now you're the one in the chair. You've got to like think about like how your whole life is different. Like that's a huge cultural, social, emotional component, how somebody views their value now, how in society, how they feel they're looked at, how all of that stuff, what does that mean culturally in their family? You've got lots of different cultures in the world who perceive disability very differently. That, well, now it's our job to just take care of them. They don't need to do anything. It's our job to take care of them. Or maybe they just avoid there's a lot of that. And you pick it up because it's awkward, right? But address it, have the conversation, and you'll be surprised how much easier it is. You'll learn a lot about that culture, about that person, about their family, and it gives them permission to maybe move a little bit forward in that grief process because you were the one willing to say it. They need to cry. They need to get it out. Well, let's talk about it. And my spiel in that situation is I'm not confining you to a chair. If they can still ambulate, I'm a therapist. I want you to stand. I want you to walk, but I don't want you to fall down. And I don't want you to be in pain. And I don't want you to sit in bed or the recliner and wish you could go and do with your family. And you're having to make that decision. Do I have enough in me to do it? Is it worth it? How about this just be a tool in your toolbox and you give yourself permission to let it look a little different today, right? And help ease them into that change. Okay. And lastly, be mindful of how you let your own cultural expectations influence your internal decision tree and how you speak to the client and their caregivers about that. Okay, moving along, coming down. Transportation, how are they going to get there? How are they currently being transported? Are they looking to get a van? Are they looking to be somewhere more accessible? What is the inside of their transportation look like? If they're going to be stay in their chair, the height, the overall height, the method of how they get in and out of the chair versus the vehicle itself, the width of the ramp, if there is one, all that kind of stuff needs to be considered. If they're carrying the chair on the outside, what's the size of the carrier, width and length versus the chair that you're asking for, and the tongue weight of the vehicle, is it even doable? I love Medea. Funding brings out my inner Medea, so that's why I put her on there. So funding is not, I put it last on purpose. What is their insurance type? What's the coverage criteria? Does the client have the ability to pay? Have this conversation from the beginning, right? Where I think it's great to educate them on what's out there, but as you educate them with what's out there, have the funding disclosure immediately behind, this is what's out there. Your insurance doesn't pay for it, but we can have that conversation, or your insurance doesn't currently pay for it. And that goes back to all the great things that we hear at ISS about, push for it, push for it, push for it. But I'm going to go back to, if you're the only one on that battle line, save your energy. Is it a need versus a want? And how can you make their wants tied to function? We do, those who write elevators, like half of your job is being a clinical professional and the other half is creative writing, right? Like you just got to word it the right way. You can say all kinds of things in a different way. So just, you can work on that. So again, forecasting the need due as well as versus the delay of acquisition. So for example, the ALS clients, a lot of times I will order ahead. What I tell people, like they're like, I know you don't need laterals right now. I know you don't feel like you need a chest support right now. I know you don't feel like you need these things, but you're going to have tough days and you will need them. I would much rather they be in your closet than you need them tomorrow. And it's a 60 to 90-day process to get them for you. And you can't tolerate being in your chair. So looking at that durability and then their access to care. This was an interesting article that I came across that followed 533 new wheelchair users from 9 model centers for SCI. 310 people reported, so that's 56%, reported needing repairs, 42% of whom experienced at least one adverse consequence lasting a median of 5 days. You can see the range there, 2 to 17 days. Repair rates were highest for the seating system, electronics, and tires. Participants were most often stranded at home or forced to use a backup chair, which resulted in out-of-pocket costs. Active users experienced more repairs. It's not shocking. Repairs were more common among those who were Black or power wheelchair users, whereas consequences were more common among those who were Black, power wheelchair, or power assist users, and those who had public insurance. So we need to consider those vulnerable populations, how terrible their insurance is, how long is it going to be when we're looking at the durability of things. So we're not creating, problems down the road. Okay, funding, what can you do to help them work around the funding issues? Again, we're back to creative writing. The insurance works the system, we can work it too. So for example, maybe they need natural fit hand rims. Their insurance includes the hand rims, it's bundled, you can't get that upgrade. Okay, so consider it as soon as you deliver the chair, write a mods order for natural fit hand rims. You see what I'm saying? Like there's ways around it that you can do that. And that's something you kind of need to work with your therapists and suppliers, work together with their funding people, have those creative conversations. But sometimes there's a workaround that you can do to end up where you want to be. Is there a down code option? Maybe they really need that group 3, but insurance only wants to pay for a group 2. Is your supplier willing to work with you? Can we all come to the table? Is there a way we can make it work for everybody? Some trial documentation requirements, be knowledgeable of that. Some are having difficult requirements for that. And is their doctor on board? Again, we need them on our side, willing to fight for the client. Alternative funding sources, consider, like there's a lot of great ones, but consider how often do they meet? So what is that delay? So maybe they want, I'm going to make up something. Maybe they want seat elevation, but they can't get it through their insurance, but maybe they could get it funded through this other organization, but that organization meets every 3 months. Are they willing to wait to go through this alternate funding, or are they willing? What's more important for the client? So just consider all of that. The ability and willingness to fundraise or get help from their community. There's lots of places that will, like community organizations that can help with ramps, community fundraising events. I think GoFundMe has become really popular. There's lots of ways that I think we can help the end user shoulder this with us. I don't think it's on us to come up with all the answers all the time. There needs to be a lot of ownership. I'm willing to die on the battle line with you, but if you're ditching out after a week, why am I dying on the battle line alone? This is not my job to fully get your chair funded. Like it needs to be a cooperative effort. Some final thoughts. It's our responsibility to bring all of these considerations to the table. They are a whole person. Look at their whole life. Okay? People appreciate knowing their options. They appreciate you taking the time to ask these questions and really dig in. It really brings a lot of value to them and a lot of great information to the table. And it reduces the chance of poor outcomes. And it reduces the chance of them saying, well, I hate this chair because I can't pick up anything off the floor. You didn't tell me that you needed to pick up. Like, when they're like, well, you didn't ask. So they don't necessarily know the information they need to give you. Client-centered model versus medical model. Pretty sure I've made that clear. A fully informed decision tends to have the most buy-in and the best outcomes. So really empowering our clients to make those decisions, leave the battle of the compromise to them. Empower them to be their best advocate and don't withhold options because of funding, but don't be the only one fighting either. And our role is to empower people for their whole life, not just for a few specific tasks. So, and manage your own burnout. Again, manage your own burnout. Like, we want everything for everybody. And I think it's beautiful and I think it's wonderful. What we do is a hard thing. It's a beautiful, wonderful thing. You really change lives. And I think we undervalue how much we do, but take care of yourself. Understand where you are in this process, getting stressed out and frustrated and wanting to blow up insurance companies and things like that. Manage your inner media, take care of yourself, have some grace for yourself that you can't fix all of it. And those are our references. Any questions? Did anybody actually scratch off things as I said them? I was curious if anybody had anything on their list that I didn't say, because I certainly don't know it all. Anybody have anything on their list we didn't cover?
We are so focused on I separate it like configuration is how the chair is ordered. Setup is, potentially what I do to alter that at the fitting as well. But planning for anticipated changes during the usual life of that piece of equipment. We don't have a crystal ball, but when we have a lot of clinical experience, we can kind of anticipate what may need to change for that client based on their illness, injury, kind of where they are, and to plan for that. So when they come in for a follow-up, you have the ability to change the chair. Right. Example, you've got a newly injured individual, with a spinal cord injury. When you saw them for their initial evaluation, they were working on level surface transfers and they had a TLSO. When they come in for the fitting of the chair, no TLSO, they're working on higher level wheelchair skills. You've got to, do a lot of changes to the setup of the chair. So knowing that with your clinical expertise and going through it in your mind and visualizing, okay, this is how I'm ordering the chair based on what's going on right now, but knowing at the fitting or potential follow-up, I'm likely going to have to change the chair in this direction, and making sure that you have room for those things in your measurements, right? Or your configuration. And that's tough. That's, again, we don't have a crystal ball, but we have a lot of experience. So
maybe AI will tell us that. Sorry.
Yeah, I mean, it can certainly probably make it easy, right?
Yeah.
I just want to make a comment about the compromise, and thank you for all these great things to think about. The compromise very often is the client needs something. Like you mentioned a couple times, air cushion. So they need something. It's the best for them, but they're a smoker. They have cats. There's needles. There's all sorts of stuff. I think it's important that's where we need to, what's our compromise? What's the priority? So we can't do without that cushion, no matter what. Let's talk to our manufacturers. Is there a different cover? Is there a hybrid version? So the front end where the butt, where the ashes drop, won't cause a hole. So those kind of things too. And I think it's important to look at where we compromise.
Mm-hmm.
And is it a strategy on the part of the client, or is it a compromise of the equipment? Because I think we're always very quick to compromise on the equipment, or the clients for sure are, no, I can't use that. Right. So, but sometimes it's more behavioral strategy that we could help with the compromise. So I just wanted to add that into the conversation.
Yeah, absolutely. Yeah. It's okay. Anyone else? Any other great thoughts? You're all brilliant people. One more time.
Actually, to the end of your presentation about doing what you can to burn out, I keep a sign on my desk that says, doing your best doesn't mean working yourself to the point of a nervous breakdown. Because that's me. So I read that multiple times a day.
That's so good.